This is Dr. Bob Miller from Johns Hopkins. I'd like to welcome you back to another podcast from the Journal of Oncology Practice from ASCO. In 2009, the American Society of Clinical Oncology and the Oncology Nursing Society, or ONS, released a set of 31 voluntary safety standards for chemotherapy administration, with a focus on outpatient settings. These standards were developed by a highly structured multi-stakeholder process, and they were published in the November 10, 2009 JCO. Well, these standards were updated recently, and their scope was expanded to include inpatient settings. These revisions were just published in the January 2012 edition of the Journal of Oncology Practice, and we wanted to highlight them for this podcast. To tell us a little more about these new revisions, I'm pleased to have as my guest Dr. Joseph Jacobson, who was one of the project co-chairs for the work group that developed the original set of standards and for the revisions. He is also first author on the manuscript in the January JOP. Dr. Jacobson is a medical oncologist and chief quality officer at the Dana-Farber Cancer Institute. He has practiced extensively both in academic and community settings. In 2002, he was among the founding members of ASCO's COPI program, or the Quality Oncology Practice Initiative, and he was COPI Steering Committee Chair until 2010. Welcome, Joe. Great to have you.
It's a pleasure to be here. Thank you.
Also with me today is Dr. Therese Mulvey, who, along with Dr. Jacobson, wrote a commentary about these revised safety standards that will be coming out in the Journal of Clinical Oncology in mid-February. Dr. Mulvey is Physician-in-Chief of South Coast Centers for Cancer Care, a comprehensive community cancer center in South Coast, Massachusetts, and she is a practicing medical oncologist. Terry, thanks for joining me as well.
Pleasure to be here, Bob.
So before we begin, let me just tell our listeners that the article that we're going to be talking about is on page 2 of the January 2012 JOP issue. However, the full text of the revised standards is actually available online only in Table A1, which is in a separate online appendix. You can find them both at jop.ascopubs.org. So now that I've gotten the housekeeping out of the way, let me start by asking Joe, what led up to the decision to revise the original 2009 guidelines? And please highlight some of the major changes.
We always expected that the standards would be living and that they would require revision both based on feedback that we received from users as well as from changes in the practice of medical oncology. So in fact, by late 2010, we had received a fair amount of feedback from ASCO and ONS members asking clarifying questions about text or asking more fundamental questions. And in the latter category, the question that came up again and again is, why did you include only the outpatient setting? Shouldn't these standards apply more generally? So when the work group came together almost exactly 1 year ago, we both focused on making changes in language for the purposes of clarification, but also with the plan to address this larger scope question. And the end product, which appears in the JOP this month and online at asco.org, describes those changes. We'll go through some of the details a little bit later, but the fundamental change again is to generalize the standards so that they apply broadly in all adult oncology settings.
I want to ask you about a few of the specific standards that I think were notable. For example, Standard 2 talks about the need to have adequate chart documentation available to the practice or institution. I think that was the new language. And that includes things like pathology reports and cancer staging. I guess my commentary is that some might interpret this as saying that this info is mostly going to be relevant for the prescribing physician and not necessarily for the pharmacist or the nurse administering the chemo. And some might say this is an undue burden. So I'm just wondering, how did the work group approach this type of issue?
Well, it's important to note that the work group was constituted by physicians and nurses, and I think in hindsight the group felt that this standard was defined a little bit too tightly, that in fact it's more than just physicians who would or will benefit from having access to this kind of chart documentation. So it's a reminder that chemotherapy safety requires a team, and that our sense was that each member of the team would be benefited by having basic knowledge, including the patient's diagnosis and details about treatment planning. It's also a way of empowering the infusion nurses who are going to be spending a lot of time with the patient going forward to be able to have, a detailed discussion with the patient that includes the facts as actually documented, rather than his or her best sense of the patient's diagnostic details.
Sure. Let me ask Terry. You practice predominantly in a community-based setting. Is this something that the infusion nurses and pharmacists in your setting, do you believe that they would find this information helpful as well?
In fact, we know that they find this very helpful. We implemented the 2009 standards both in our inpatient and outpatient center simultaneously, in large part because we are a community group that is employed by the hospital. So to do it one place and not do it the other didn't make sense at the time. And we found the feedback from the nurses, knowing about the patient's real pathology, their actual documented pathology, and their staging was incredibly important. Again, as Joe said, they spend so much time with the patient, and they do so much of the teaching, not just about the actual infusion itself. They also have the opportunity to do a lot of teaching around the disease and what to expect in the future, as well as discuss the psychosocial aspects of the disease with the patient. And having that concrete information made a huge difference to those folks. And it really reinforces the importance of working on a team.
Let me ask you about another one. This was Standard 20. Again, this is from the Appendix Table A1. In this standard, there is a requirement that a licensed practitioner be present on site and immediately available during chemo administration. Now, I think we all are familiar with the Incident 2 rules for billing, but I gather in reading the manuscript that during the public comment period, there was maybe a little bit of discussion about some concern about this being different for the inpatient setting. What do you guys think? Is that applies to the inpatient setting as equally to the outpatient setting?
I think the answer is yes to that. And what you're alluding to is that when we opened the standards review up to public comment, we had 18% of respondents who didn't completely agree with the idea that this licensed independent practitioner needed to be present on the inpatient setting, and they worried that that might be challenging in an institution like a hospital that's open 24/7. Our answer to that concern was really to not worry too much and to go back to the definition of a licensed independent practitioner, which broadly includes not just physicians, but advanced practice nurses, physician assistants. It varies somewhat state by state, but a hospital setting may not have a medical oncologist who's available physically 24 hours a day, but there will be in almost all settings someone who would meet the criteria for a licensed independent practitioner. We recognized that this was a concern, but didn't think it was insurmountable in the kind of settings that we had in mind. Additionally, in the home setting, if a patient is receiving infusional chemotherapy, or if they're in an extended care facility, the requirement is only that the patient and or family or other responsible person know who to contact on an urgent basis.
I see. Let me ask you about Standard 16. So this is about informed consent, and I assume that's referring to specific written, signed informed consent for chemotherapy administration. I've learned fairly recently that there are some substantial regional and practice variation differences on this issue. Again, how was this reconciled in the final document?
We created a fair amount of room for this standard to achieve compliance. So first off, we don't require signed patient consent. We allow practices to either document consent somewhere within the record, so that to document that the discussion occurred, or to provide signed patient consent. So we were fairly loose in the definition, and that complies with earlier ASCO recommendations about informed consent. And then, just as you learned, we found, as we learned about practices around the country, that there is some variation. And in academic settings, for example, where patients are enrolling in clinical trials, there may be multiple visits before informed consent is finally obtained, and in those settings, the final document is often signed in the presence of a research nurse rather than a physician or another licensed independent practitioner. So we thought on this standard that we should be quite broad so that we reflect actual practice in the community without straying away from any concerns for patient safety.
Sure. How about, Terry, is that similar in your institution?
Exactly.
So let me talk about, there was a companion article. This was actually in the Journal of Clinical Oncology, and I'm not sure when this is coming out relative to when this podcast will go live, but this was going to be a commentary that Terry and Joe wrote about these standards. And I just want to read one quote. This is a direct quote from your commentary. Quote, "Inpatient chemotherapy administration, especially in the community setting, is felt to pose a silent but growing threat to patient safety." That's pretty stark. Can you elaborate on that comment a little bit, Terry?
Sure. Right now, prior to the publication of these standards, inpatient chemotherapy would happen on such an infrequent basis in most community hospitals that the competencies of those involved in the delivery and mixing of the chemotherapy may be somewhat challenging. More patients are moving in and out of the hospital setting at such a rapid pace that documentation may also not catch up with the patient. This may have to do with electronic health records and their interfaces. It may have to do with dictations and paper charts. And with patients being shuttled between the inpatient and outpatient setting, sometimes that's happening because of financial constraints with the practice or with the patients themselves. And so information transfer is one of the areas that we find to be of a big challenge. Another is nurse and pharmacy competencies. If this is something that you're trained to do but only do it once or twice a year, then how does one really measure that competency? The other issue is, how does a hospital measure things such as evidence-based practice? How do they manage patient education, pre- and post-treatment, and how is follow-up ensured? So I think all of these issues are things that the patient faces when they come to the hospital for a discrete event that is actually part of a much larger continuum of healthcare for that patient. So that's in large part why we felt that this was a growing threat, the financial side of it, but the silent threat, because if it happens infrequently, one may not know about problems incurred by that patient.
That sounds like an important change, because certainly maybe 10 years ago it was fairly unusual, at least in the settings where I spent most of my time in practice, to use these hospital infusion centers, and certainly the inpatient setting. So I gather the changes in insurance and some of the reimbursement models changing may have driven some of that. Is that what your take is as well?
Absolutely. The largest problem is the growing number of uninsured patients,
right,
or patients that may be underinsured, such as those patients who have Medicare with no secondary. This is a difficult group for a practice in the community setting to take on. And so therefore the hospital is a place where they can receive their chemotherapy without causing an undue financial burden to either the practice or the patient.
Mm-hmm. Let me ask, Joe, you've been involved with the ASCO COPI program from the very beginning, and I understand that these administration standards have now a formal relationship with COPI, but I'm not sure I fully understand the connection. Can you elaborate on that a little bit?
Yes. So COPI, the Quality Oncology Practice Initiative, as you know, is a voluntary program. It's a free service provided by ASCO to U.S. members. A couple of years ago, ASCO and COPI gave birth to a COPI certification program, and there are now, I think, 105 programs certified across the country. Certification allows practices to achieve a higher standard than COPI participation alone, and it requires two components. The first is that practices have to achieve a certain threshold score for a subset of the COPI measures that actually cover about five of our 6 modules. The second requirement is that practices are able to demonstrate that they have adherence to 17 of the 31 ASCO ONS chemotherapy administration safety standards. And they first have to document on a checklist that they're compliant. Then they need to submit documentation for selected standards in terms of their policy and procedures. And now for almost all practices, we do an on-site audit done by nurses who have a great deal of experience doing this kind of work, who actually go through the practice to be certain that those 17 chemotherapy administration standards are in place.
So it sounds like it's a combination of self-attestation and, in selected cases, actually on-site visits to sort of check compliance and on-site. Is that correct?
That's correct. Our goal is for 100% on-site audits, and we're getting very close to that going forward. Practices, just by the way, find the audits to be incredibly valuable, and that's partly why we're pushing to make this a standard part of becoming certified.
Sure. So looking to the future with this set of standards, there were 3 areas that you briefly mentioned in the manuscript that were basically not in the scope of this document. One was oral chemotherapy administration. I think a second was sort of mapping drug interactions with chemo versus the non-chemo agents the patients were taking concurrently. And the third you sort of alluded to already, Joe, was home infusion. Is there any plan in the future to address these with a guideline specific to that or update of this set of guidelines?
Yes. So back to the point that the standards really are a great example of a living document. A couple of months ago, ASCO and ONS brought together another large group of stakeholders to begin to address concerns about the safety of oral chemotherapy administration, including the standard agents and new targeted agents. It was a wonderful meeting with representatives who had been at the original meeting as well as others. And the final product from that meeting is still being developed, but there will be an additional set of standards that focus solely on oral chemotherapy. And then there will be further modification of some of the existing standards to more closely be able to address oral chemotherapy safety. In addition, the group began tackling one of the most difficult problems in medicine today, and that is medication reconciliation.
Oh, yes.
And I won't say that we've nailed it, but we've tightened language in the standards so that that some sort of process is undertaken when patients are being seen at the time of drug administration or when they're starting on a new oral agent or being seen in follow-up. The last piece, I would say we'll have to wait for yet one more revision of the standards, and that is how to manage patients at home, how to guarantee their safety when they're receiving infusional therapy is still a challenge for us. We've tightened the language a little bit, but I would say that there is room to do better, and we imagine that this is going to be a growing, part of our business going forward.
Absolutely. Let me ask you both. You note in the commentary piece in the JCO that the Joint Commission and the American College of Surgeons Commission on Cancer, at least to date, really haven't focused on the safety of patients receiving chemotherapy in the hospitals and the cancer centers that they're responsible for accrediting. Is that something, in your opinion, is that something that these organizations really should be involved with from a regulatory standpoint?
I think yes, particularly the Commission on Cancer. This is an area where they should have tremendous interest around patient safety and quality of care. It dovetails with their mission of providing safe therapy for patients in accredited centers. The Joint Commission similarly looks at the safety of medications in the hospital setting. It's a fairly generic look, but specific to chemotherapy, now that these guidelines are in the public domain, should be part of what they assess.
I agree completely. Terry and I began this conversation well over a year ago, beginning with the conviction that this was a great opportunity for the Commission on Cancer and the Joint Commission to play a role in chemotherapy safety.
So how difficult do you think these standards really are to implement in various practice settings?
Having implemented these in an inpatient setting across 3 community hospitals, I can tell you that it really does require the team. The nursing guidance, as well as pharmacy input and pharmacy guidance. Patient advocates such as social workers are required to really make sure that these policies, procedures, and standards are part of the living documents that patients are cared for under. Like any other policy or procedure in the hospital, these have to be addressed regularly and competencies assessed ongoing. The implementation of this required substantial changes in practice of what we all thought we were doing well. Mm-hmm. The interesting part of this has been the ongoing monitoring to ensure that the standards are being met. And so for the first 6 months, in our experience, everyone was 100% compliant. But by 9 months, we're about 90% compliant. Mm-hmm. So this really does take a sustained effort on the part of those involved and a constant reminder that these standards need to be adhered to on an ongoing basis.
Dr. Jacobson and Dr. Mulvey, I really appreciate your both sharing your insights on this important topic today.
Thank you.
Thank you.
So I want to thank our loyal listeners and any new listeners for taking the time to download these podcasts. It's a new year, and I am still waiting for my first iTunes comment. So make my day and tell us what you think about these podcasts by commenting on our iTunes Store podcast page or by email at jopeditorsdesk@asco.org. We'll be back in a few weeks with another podcast from the JOP. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.